My name is Rahul Gupta. This is a lecture that I'm giving from home for the 2020 American Academy of Optometry meeting. It's a little bit odd to sit on your couch and do this, but obviously in the context of COVID-19, this is how we're recording them, so we'll see how it goes. This lecture is for the AMCO SIG, the American Medical-Center of Optometrists Special Interest Group. And essentially, it's supposed to be kind of like an M&M meeting that we have in hospitals. So M&M meetings are morbidity and mortality meetings when doctors come together periodically to talk about cases that they've had, how things could have gone wrong or how they did go wrong, and what could be done to prevent. Hang on, I'm trying to pull up my notes. And what could be done to prevent that from happening again in the future. The goal ends up being to have an environment where fingers are not pointed and no one is really blamed, including the doctors who are giving the lectures. But instead, we can kind of learn from one another and figure out if there are systemic changes we can make to prevent these sorts of things from happening again in the future. I have no financial disclosures. So our case is a 56-year-old white man who came in. He was sent in on referral from an outside eye office where he'd been seen 9 days ago and diagnosed with severe NPDR in both eyes. He had kind of a standard cardiovascular history, at least in our patient population. Even though he was relatively young in our patient population, he was diabetic, hypertensive, he had high cholesterol. He was taking a diabetic med that I had to look up, including how to pronounce it. I'm not going to try. Empagliflozin. There you go. And he had no significant cardioembolic history. We didn't remember to ask whether he's a smoker or not. And at our VA, we don't check blood pressure when the patient comes in. So on the next screen, when you see it, it'll be something we got at the end of his examination because of his presentation. And of import in this case, he wasn't taking any anticoagulants or any antiplatelet drugs, including no aspirin. On questioning, the patient said his blood sugar was poorly controlled. His sugar the night before had been 157. His A1C was 8.4 3.5 months ago. And he said that in the right eye, about 3 weeks ago, which would have been 2 weeks before he went to see the outside eye office, he had an episode of severe GI upset, and he went to sleep. It wasn't getting better. He didn't have any flu-like symptoms. He didn't take any medication for it. When he woke up, then he noticed in the right eye he had a scotoma straight in the middle, a black spot, he said, in the middle of his vision, and it expanded outward as well, a little bit more so supratemporally. He went to sleep, and then when he woke up again, he said the scotoma was much better, but he did have a residual supratemporal area where he had difficulty seeing. He said the scotoma had been getting better over time. Over those 3 weeks, it had improved and continued to do so, but the most dramatic improvement was from the time that he went to sleep, the second time he went to sleep and woke up in the morning again. The left eye was fine and unremarkable. The vision was 20/20 -2 in the right eye. IOPs were 18. His pupils were fine. EOMs were fine. It's not on the slide, but his confrontations were noted as fine as well. So we work with trainees at our clinic. We have externs and residents there. This patient, as it usually goes, was seen on a Friday. It was the last patient. He was the last patient of the day, so around 3 o'clock or so. And the way you do confrontations will make quite a difference. So there are a lot of different ways to do it. You can check for neglect, not check for neglect. You can do central, peripheral, look at my face, and facial amsler. In this case, whichever method our extern used for confrontation fields, which I'm sure is not an uncommon method, didn't show any scotoma. The blood pressure down there, 115/82, pulse 70, strong and steady, is information that was collected at the end of the examination. We don't, probably unfortunately, we don't check it on every patient when they come in for an examination. The patient's exam was unremarkable. In the front of the eyes, he had mild cataract, NS1 in both eyes, and in the back of the eye, the fundus photos are on the screen there. The eyes looked pretty symmetric. His nerves were small to moderate in size. They were quite congested. It didn't look like there was any pallor, hemorrhage, or edema. The arteries were mildly sclerotic, but they also looked that way because the veins were so large and tortuous in each eye. The tortuosity was symmetric. It was symmetric within each eye, superior versus inferior, nasal versus temporal, as well as between the two eyes. And I felt probably there's some chronic hypertensive component, but also just the way that the discs look, that in and of itself can give congested and dilated and tortuous veins. The patient's refractive error was a +6, -3 against a rule or so in each eye. Before all this, we decided, he might get contact lenses in the future. Sorry, we didn't decide it before this. At one of his follow-up visits, we talked about contact lenses and decided that we would pursue that fitting, so we got Scheimpflug Pennicam imaging on him, and his axial length in the right eye was 21.64 or such, and that equates to about 7 diopters of quote-unquote axial hyperopia. So I don't think that the venous appearance here, which is quite striking, is just because of hypertension. I think a fair amount of it is probably because he has a small eye with a small, tight nerve. Anyway, on the right eye, everything looked fine with the exception of these 3 cotton wool spots. There was no hemorrhage anywhere. The fovea looked just fine, at least on clinical examination. And given what's coming up, this is obviously a lecture on P.A.M.M. I then went back and looked again. On the photos, there are a couple of little spots you can see here and here. Those are just small drusen, and they're not retinal emboli. Everything clinically looked perfectly unremarkable. And now, of note, I don't know how he looked 3 weeks ago, because this is 3 weeks down the line. We obtained angiography on him, and this is an 8x8 montage angio, so it's 5 8x8 OCT angios that are stitched together. We use a Cirrus at the VA here. An 8x8 angio is 26.6 bar degrees by 26. The typical angio we do, a 512-128, is a 20-degree scan. The 8x8 is a 26.6 degree bar scan, and when you stitch them together, you have a 2 millimeter overlap. So altogether, from edge to edge, this is 46.6 bars by 46.6 bar degrees. So significantly smaller than ultra-wide field confocal scanning laser ophthalmoscopy like Optos and such. Significantly smaller than that, I should say. Those got to about 133 degrees. But quite a lot more than we would traditionally expect. A fundus photograph is usually only about 45 degrees, and this gives us a little bit more coverage than that. This is full retinal thickness, so it's going everywhere from the ILM down to the RP, and all the vasculature looks fine. There are quite a lot of motion artifacts down here. This entire area here being hyperreflective is artifactual, and one of the ways you can tell that is the vessels themselves are very gray and shaky looking. It's not an area where everything around it looks fine and there's a black in the middle, which indicates actual infarction. You can see a little bit of an artifact here from where the cotton wool spot lies. But when you see just kind of messy grayishness like this, that's some type of mediopacity that's in the way. We got standard MAC OCTs on him. These are 512-128 cubes, and they're both quite thick with the exception of the inferior area here, obviously in the right eye. The mean thickness was 293 on the right eye, 304 on the left eye. The central retinal thickness, which is in this little 1 millimeter area in the middle, was 328 in the right eye, 325 in the left eye. Typically, the numbers for these, the total thickness number is about 280, and the central retinal thickness number also is about 280, and that gets averaged out because the ring around the middle is thicker than 280. It might be 320 or so. In this patient's eye, these are not abnormal. There's no retinal thickening in the left eye. The reason it looks like that is the eye is short, so everything is congested within it. This is one of the B scans on that same OCT. It's located slightly above the horizontal midline, kind of right around there. And you can see there's a hyperreflective placoid lesion in the inner nuclear layer here from about there down to there. And right below it, this area is going to be somewhere down here. There's a continuation of that. So even though on here they look like 2 separate lesions, it's in this entire contiguous arcuate area. And again, it's the hyperreflectivity is going from the anterior aspect of the INL to the posterior aspect, and everything outside of that is preserved. You can see on here, I can't go back in this recording mode, all of the RP and outer retina looks hyper-reflective, and that's because you have a shadowing artifact. You have that same type of shadowing artifact down here. If you have something hyper-reflective in the front, it's going to block your signal going backward, and everything behind it will look naturally hypo-reflective. This is the patient's cotton wool spot that we saw in exam. We're running low on time here, so I'm going to blast through a lot of these OCTs because the point of this lecture isn't quite as much P.A.M.M. As it is how things went wrong, and it's actually supposed to more be about how the case was managed and how that could have ended in significant issues. This is an ANFA, so this is a C scan. It's a very, very helpful way to look at certain things. It's very valuable in hydroxychloroquine maculopathy and also as well So OCTs are just a bunch of B scans. B scans are just a bunch of A scans. They're optical instead of ultrasonographic. If you take those B scans and you flip them, and instead of looking at them as cross sections, you look at them head on, then you can segment out regions, layers of the OCT, and average out the reflectance pattern between that. So this scan here is a C scan, and what it's done, I've manually done it because the automated algorithms aren't great, is it's manually segmented the INL area of the retina, and you can see very easily this hyperreflective arcuate lesion here, and that reflects this P.A.M.M lesion. This big area here is a cotton wool spot. All of this stuff is nerve fiber layer, and this is, bear in mind, it's not an angio. That's why anything that's hyperreflective will look very hyperreflective. It's not showing us blood flow or anything like that. We got a 10-degree visual field on him. As I said, the student performed an Amsler grid, and the patient described having a superior temporal scotoma. 10-degree visual field from edge to edge covers the same area as an Amsler grid. And the patient's 10-degree field, this is the left eye, left on left, right on right. The left eye had a mild inferior depression. This entire region here, you would expect these numbers in pretty much any patient to be in the 30s or so. On the left eye, he had a very dense superior nasal scotoma, as well as a mild diffuse depression. I typically will look at total deviation maps instead of pattern deviation. Pattern deviation just throws out a lot of true defects. It bothers me when I hear it called a cataract map. And this is a 10-degree field side by side with that enfas, and if you overlay them on each other, you can see that very well that inferior arcuate P.A.M.M lesion corresponds to the superior visual field defect. It is worse supranasally on 10-degree field, even though the patient subjectively describes it worse as being supratemporal. So what is P.A.M.M? It's a confusing question with lots of different answers. This one is easy. It's not my image. You can see eye rounds at the top left. This is a central retinal artery occlusion. And central retinal artery occlusions occur usually, they're embolic. Their other etiology can be GCA, so you always want to work up for GCA, especially if your patient's more than 50 years of age. To quickly trace out our vascular pathway, blood gets from the heart through the brachiocephalic on the right side, the common carotid on the left side, and the subclavians for posterior circulation. Blood travels up your common carotid, splits at the bifurcation. The internal carotid goes posteriorly. It's the part that comes into the head through the carotid canal. It goes through the cavernous sinus, siphons around, gives off the ophthalmic artery there, and then it continues going backward near the chiasm, gives off the MCA and the P.C.O.M and all that. The ophthalmic artery comes into the orbit. It continues forward as a ciliary artery, and then the central retinal artery pierces through the optic nerve, comes into the eyeball, and gives off a distribution of the central retinal artery that then continues bifurcating. And if you have an occlusion here, again, usually an embolic occlusion, this is a lamina cribrosa, then you can get a central retinal artery. Something that's greatly expanded upon our understanding of what's going on with these different occlusions is OCT, and on top of that, OCT-angiography. So as that major central retinal artery comes into the eye, it spreads across the superficial retina and the nerve fiber layer. Those vessels get smaller, they dip down and spread out in the ganglion cell body layer, then they dip down and they're smaller and they spread out at the anterior aspect of the internuclear layer, the bipolar cells, and they dip down and they spread out again at the posterior aspect of the internuclear layer, the bipolar cells. And so you get your superficial, intermediate, and deep plexi. The idea with P.A.M.M is that deep plexus probably is what's being infarcted, and that's causing edema of the INL. And again, that deep plexus would be this region around here, or on the OCT, it would be this region around here. Initially, P.A.M.M was described as AMN, acute macular neuroretinopathy, in 1975 by Bose and Duttmann in 4 young white women. And since then, that evolution and that concept has evolved quite a lot. And there's more recent idea now with OCT and OCT-angiography that AMN might be kind of maybe a variant of one of the white dot syndromes. It's been described as a variant of acute multifocal posterior pigment epithelialopathy. So maybe more of a choroid and choriocapillaris disorder, whereas P.A.M.M maybe is more of a retinal disorder along the spectrum of C.R.A.O, B.R.A.O. This and the one you just said, these are actually our patients. Angiograms are manually segmented choriocapillaris layers. The one you just saw before this slide was baseline. This one is the patient's 1-month examination and this is the patient's 5-month follow-up exam, so 6 months or so after his onset of symptoms. In all of them, you can see that things look pretty much normal. There are no areas of infarction. In this image, around the optic nerve is a large area of hyperreflectivity, and that's hyporeflectivity, and that's simply because of segmentation problems. If you're not cutting exactly through one particular lamella, then you're going to get hyper or relative hyperreflectivity. Further ground in the fact that optical angiography has been indispensable in helping us understand P.A.M.M and A.M.N and all these types of disorders. The top left here is the same as you just saw. It's the 5-month follow-up of the patient, choriocapillaris segmentation. The one on the right is the superficial retina going from the internal limiting membrane down kind of to the posterior aspect of the nerve fibular, and you can see that everything at the front here is normal of the eye and everything way back in the choroid is normal. And I think we'll be able to, toward the end of the lecture, see how the actual affected deep plexus in the patient looks instead. So what did we do for our patient? What should we do for a patient in this case? Well, with P.A.M., there's no clear answer. And one thing that helped lean me one way in his case was he didn't have just P.A.M., but he also had the cotton wool spots. And there was a question of, is this his P.A.M.? Is this P.A.M. that's one of the evolutionary or waning stages of an old branch retinal artery occlusion? Exactly what's going on? So in his case, I had enough concern that we figured I don't think you need to go to the ER. Whatever happened about 3 weeks ago. And usually if you're going to have something occur, even after a full-on branch retinal artery occlusion or such, it tends to happen very quickly. Now, very quickly might be within the first week or 2 weeks or up to a month. In his case, it looked like a pretty small area. A pretty small lesion that had been resolving gradually over time. So I figured we don't have to send him to the ER. Let's just go ahead and rule out something severe by getting a carotid, rule out GCA by getting CBC, diff platelets, commetabolic panel, set him CRP, and then we'll get the results and we'll see him after that. I'll copy his primary care physician, let him know what's going on. One of the things that'll help determine just how urgent a case is patient symptoms. If your patient has acute symptoms, if the cranial nerves are involved, especially if it's a cranial nerve in the same area as other nerves, so let's say a patient has diplopia and 5, 6, 7, and 8 kind of sit together. If one or more of the others in that region, one of the other pontine nuclei is being affected, that's more concerning than if it's an isolated palsy of a nerve. There are a lot of things that could be done. List is extensive. Typically, if I see a retinal embolus, I'll get an echocarotid and Holter. If the patient has an established history of cardiac disease, then I won't get the cardiac stuff, the Holter or the echo. I'll defer that to primary care or cardiology if the patient has a cardiologist to let them determine if the patient needs an update or not. So the patient underwent same-day carotid ultrasound. I was not alerted of the results. I went home and out of curiosity, I looked at them, and he had a severe area of blockage. This is the carotid bulb, and you can see this massive plaque. This is the ICA, this is the ECA, and this is the common carotid artery. I looked at his numbers as well, though honestly at this point it didn't matter that much. Let's see if we can them up here. His peak systolic velocity on the ICA was 167, in the middle of the ICA was 175. There are different ways in which you can grade stenosis. There's the NACET system, the European Carotid Surgery Trial system. On ultrasounds, you can actually look at flow, so you'll often go 125 to 230 is 50 to 70 stenosis. Greater than 230 is greater than 70 stenosis. Let's get back to finishing up with our case here. This is a reiteration of the patient's fundus photograph at his initial examination at baseline. And now on the left side you have your 1-month image, and on the right side you have your 5-month image. At 1 month the cotton wool spots were getting better, but he also had a new nerve fibular hemorrhage infratemporally, indicating, so there are different ways to grade, say, hypertensive retinopathy. Keith Wagner-Barker from 1939 is a system that we learn in school, usually I think even now talking to students. I personally like to think of it as an acute condition versus a chronic condition. Hemorrhage is something that's acute. Cotton wool spots are something that are acute. Disc edema is something that's acute. Arteriosclerotic changes and AV crossing changes to me are chronic, and they are chronic. And so I tend to think of those two things separately, and then within that I grade mild, moderate, severe, whatever my impression tells me. Anyway, at 5 months after his initial presentation, the fundus this looked stable. It looked fine. Everything had resolved, and the vascular appearance was the same as well. His nerve fibrillary OCT we didn't get at his initial visit, so this is at his 1-month exam, and his values are very thick in both eyes. You can see that there's some green in the background here, and that's either because he was built that way, or he has an epiretinal membrane, or there's background gliosis. In his case, we know the retina at the macula is very thick. We know he's a high hyperope, and this is just the way he was put together. We did it again, and this is at the 5-month exam, so it's 5 months after his initial presentation, 6 months after whatever happened after his embolic, at least we're going to suppose embolic event occurred. And you can see down here he's developed a little bit of a nerve fibrillary defect. Repeated visual field at that 5-month visit as well. It had gotten significantly better. His total deviation map looks about the same as it did at baseline, but that's because these close to black spots are as black can get on a 10-degree visual field. There's no P less than 0.5%, so they're never going to be completely black boxes the way we see and are used to on 24 or 30-degree visual fields. His numbers got much better, so if he had a 25 and a 9 here, now he had a 9 and an 8. His 15 became a 10. His 16 became a 7. A 3 decibel difference mathematically is a 50% change in sensitivity. His OCTs we have from baseline. Here's what we saw early on in the lectures. There's that placoid lesion at the superior part of the one contiguous lesion. Here's the inferior aspect of that one contiguous lesion. Here's that cotton wool spot. 1 month after evaluation, you can still see some hyperreflectivity here and here, but the INFL itself is thinner. And 5 months afterward, the hyperreflectivity is pretty much gone here. You can still see a little sliver up here, and there's significant atrophy of that internuclear layer that became infarcted. It's mostly the inner retina that is being affected. The outer retina stayed fine. So even at baseline, his ganglion cell layer, which on the serous includes the ganglion cell bodies and the inner plexiform layer, so it doesn't actually include the INL, was significantly atrophied already. So that means he had thickening onset, some with thickening of the retina, and an artery occlusion at least begins within several hours of the event. Kind of like if you think of it as a diffusion-weighted MRI, you start seeing hyperintensity within several hours. And then atrophy occurs over who knows how long. You know, we don't tend to have patients in our chair and image them every 12 hours for 60 days. But in his case, assuming that he was fine before the onset of his event, this had significantly atrophied just about 3 weeks after. And then it continued to do so here, and it continued to do so further here, and it may continue more for the next year or more. This is manually segmented OCT angiography. Up here we have the choriocapillaris slab, which looks fine. This is just an artifact because of segmentation. This is a superficial layer of the retina, and this is a manually segmented deep intermediate capillary region of the retina. And all of this is where the retina has thinned out and the vascular perfusion has been lost. This is that same en face image we saw early in the lecture, and this is how it looked 5 months after onset. We can see that placoid hyperreflective lesion here is now atrophied, and it's become hyporeflective. This is the same as on the previous slide, except this is the 8x8 angio version. It has higher resolution, and it also gets you out a little bit farther. We do remain with the dilemma of what to do with these patients when they come in, and at least to offer some encouragement now, the American Academy of Ophthalmology last year in 2019, toward the end of the year, published new guidelines for managing patients with ophthalmic and central retinal artery occlusions, and they decided it is an emergency, well, a stroke center presentation for a patient. Emergency room if you can't find a stroke center, and it's not something that should be managed on an outpatient basis. Historically, people have considered, there have been surveys several years ago, one of the ones that's cited showed that in these cases, about 85% of neuro-ophthalmologists consider it an emergency, about 70% of neurologists, and only about 35% of ophthalmologists, and that about 85% of retina doctors have this worked up on an outpatient basis. That thinking has significantly shifted over time. Now that's with artery occlusions. One would have to decide whether transient monocular vision loss, amaurosis fugax with no anatomic changes on examination, fluorescein angiography, or OCT should be in that same category. And one of the difficult things there is to figure out if the patient actually had amaurosis, or if it says dry eye or refractive error, the patient blinked or sneezed, or it's a migraine or something rather more benign. And P.A.M.M is even less well studied. Again, it's been described as P.A.M.M only since the early 2010s or so. So the numbers can be quite frightening depending on what you read. There's a paper by Chancellor from a couple of years ago in Journal of Neuro-Ophthalmology. There's a paper by Valerie Busset in Ophthalmology in 2018. And these meta-analyses try to figure out, looking at a bunch of little studies here and there and then bigger papers as well, what are the odds, what's the incidence where if you come into the office complaining about transient monocular vision loss or showing a retinal artery occlusion, whether it's a branch or a central, that when you're taken over to the emergency room and you have a diffusion-weighted MRI within 7 days, you're going to have diffusion restriction indicating an acute infarction. And the best numbers, the numbers with which I've come away most comfortable, are that about 30% of CRAO patients, about 25% of branch occlusion patients, and about 10% of patients with amaurosis fugax actually have diffusion restriction on their MRI when you get it within a week. The numbers you see at the bottom there are the 50% hemiplegic TIA and the 20% transient monocular vision loss CVA. These are figures from NACET, the North American Symptomatic Carotid Endarterectomy Trial that was conducted in the late 80s, early 90s, and published in 1991. And I think this paper is from 2001, and it looked at the likelihood of developing a stroke within 2 years if you had traditional symptoms of hemiparesis versus if you had symptoms only of transient monocular vision loss in patients who had severe ipsilateral carotid disease. And the group with the hemiparesis had significantly higher risk of developing stroke, whereas transient monocular vision loss was only 20%. The hemiplegic patients were 50%. And so there's this argument that people have taken amaurosis fugax less seriously because it's so much less concerning than hemiparesis, but 20%, 1 out of 5, is still hardly a number that puts one's mind at ease. Just before proceeding to wrap up with the case, it'd be nice to just run through a timeline of what happened and how it happened. So this patient came in toward the end of February on a Friday afternoon complaining of an episode of transient monocular vision loss 3 weeks ago when he had an episode of severe stomach upset. On that same day, when he presented to me, I ordered labs to rule out GCA and a carotid ultrasound to rule out severe stenosis. The lab results were negative. The stenosis results were not conveyed to me. When I came home and I looked at his ultrasound, then I saw that he had a large plaque sitting at just the right place to cause an event like this. Now, the reason the results might not have been conveyed is there are thresholds, and once you hit those thresholds, then it's tagged as a critical result, and the ordering provider is alerted, and the patient is kept on site. His ICA velocity came out to 175 centimeters a second, if we recall, and I don't remember whether I said this or not. I think I did. Once you hit a 230 centimeter a second velocity in your ICA, that's tagged as a 50 to 70, as a greater than 70% stenosis, and that's a critical result at our hospital. If the ratio is greater than 4, then that's a greater than 70% stenosis. That's tagged as a critical result. In his case, the 175 centimeter a second was still in the 50 to 70% stenosis range, and the ratio came out to a 3.0 because his common carotid peak systolic velocity was only a 59. And that's also not going to put you in the greater than 70 range. So all of that happened on Friday. On that same Friday, looking at the carotid ultrasound, I called the emergency room at the clinic and requested that they call the patient and have him come in and be worked up for a stroke, and explain the reason for that is the carotid ultrasound finding in the context of the patient's symptoms and retinal examination. The ER called the patient, but the patient was not requested to come back to the hospital. Instead, the ER attending told the patient to be aware of stroke-like symptoms and if they occurred to take an ambulance to the nearest emergency room. So then that Monday, which would be 2 days later, the primary care physician, whom I'd alerted on everything going on that Friday, just in a tag on my note, called me up and said, I looked at everything. I looked at the carotids as well as your chart, and I need to update you that nothing has happened as yet. The patient hasn't seen any specialists and hasn't been recalled. I agree with you that he should be placed on 81 milligrams of aspirin. I've asked my nurse to call him and tell him that. What is it that you'd like to do next? So on my part at that point, I decided he should be seen by neurology and vascular surgery that same week. It didn't seem like a same day thing. And I specifically called neurology and vascular surgery to make sure that they could see the patient, and they did. Neurology saw him 2 days after that on Wednesday. They assessed him and said, we'll get a head CT scan, no contrast, just to make sure there's nothing acute on there. They did, and there was not. Vascular surgery saw him the next day, so that would have been the Thursday of that week. And they said they don't believe there's an association between the retinal examination and the carotid ultrasound findings, and that the patient should continue on 81 milligrams of aspirin and be told of any emergent symptoms. They did plan for him to have a CTA, but that was a little bit of a ways out. And by that I mean it was a month out. So 1 month after he was assessed by vascular surgery, he had the MRI, which had actually been ordered by neurology. So the CT happened that week. A month after that, in mid to late March, he had a brain MRI as well as a CTA of the head and neck on the same day. The brain MRI was negative for anything, including for old infarctions, and the CTA corroborated the results of the ultrasound. And looking at the CTA, they found that the magnitude of stenosis was 80%. The patient was scheduled by vascular surgery to undergo ipsilateral carotid endarterectomy. He did so. This was around May, and his aspirin dose was increased from 81 to 325 milligrams. He wasn't placed on warfarin, apixaban, rivaroxaban, dabigatran, or any of those things. So the timeline comes down to episode was experienced. 3 weeks later, the patient presented to the eye doctor. Eye doctor ordered lab work and carotids. The patient was not brought back for hospitalization. 2 days after that, the eye doctor was alerted and entered referrals to vascular surgery and neurology. That same week, a head CT was obtained that was negative. A month after that, an MRI and a CTA of the neck and head were obtained that corroborated critical vascular stenosis, carotid artery stenosis. And 2 months after that, in May, the patient underwent carotid endarterectomy and his aspirin dosage was increased from 81 to 325 milligrams. Well, ultimately, how do we feel we did in this case? On one hand, we feel fine. Everything worked out. We had a patient come in. He had a symptom. We got OCTs. We found something. We sent him to the ER. We got blood work. We got a carotid ultrasound. We made a hit. We had a hit. The patient ended up having an endarterectomy, being placed on aspirin. One hopes we've prevented him from going blind or having paralysis or dying. So we did a good job. On the other hand, maybe we didn't do so great. The results of the carotid ultrasound were critical, but they weren't read that way, and they weren't conveyed to the doctor, and they weren't conveyed to the patient. The patient went home. He may have stroked out at home instead of at a hospital. The patient wasn't placed on aspirin. The ordering doctor spoke with the ER doctor, but it wasn't properly communicated to the ER doctor just how large the magnitude of concern was. And so the ER doctor didn't feel that the patient needed to come into the hospital and instead just relayed symptoms to him. Once the patient was seen by neurology and vascular surgery, the vascular surgeon didn't feel that there was an immediate connection between what the eye doctor saw in the eye and what was found in the carotid ultrasound. So communication is one of the things that broke down. Another thing is, honestly, education on my part. I'm still not quite sure to what extent I will show concern if I see P.A.M. P.A.M. is not so well studied as C.R.A.O. or B.R.A.O. or amaurosis fugax, and even those are evolving concepts that only last year were endorsed by the American Academy of Ophthalmology to be medical emergencies, let alone something like P.A.M. So an expansion of education on our part, and to be aware of the literature that's being published, and to stay on top of it, because things evolve very, very quickly, especially as technology is able to uncover new mechanisms of pathology, and from that we can develop new ideas about exactly how serious different conditions are. It's questionable, when do you image someone, when do you send someone somewhere? At the very least, if there is unexplained vision loss, even in cases where a patient says, yes, I have a problem in the middle of my vision and the visual acuity is just fine, if you have the luxury of having access to an OCT, getting those studies will show us subclinical things. Earlier on, one might, kind of make the argument, well, if I don't see it on an examination, then my OCT is probably not going to show me something. I mean, if there's a foveal reflex, what are the chances the OCT is going to show me edema? Well, reasonable. This isn't even edema like one would have in diabetic retinopathy where you see cystic changes. There is overwhelming reason that there's overwhelming likelihood that you're not going to see lesions like this on your clinical examination. Give David pumpkins. I thought this lecture would be a little bit closer to Halloween. If you have questions, then please write. I'm sorry if the way this was put together is maybe not ideal. It's a little bit jumping here and there. You can tell probably that instead of being able to sit as one long lecture, there are a couple of slides where I've had to go back and re-record a few things, so it might be somewhat cut up here and there. Anyway, thank you very much. I hope you enjoyed the meeting, or however you're gaining access to it during this year. All the best to everyone. All the best with your health and your safety. Goodbye.